Are the slides visible?
Yeah, your slides are visible. Yeah, fine. Perfect.
Okay. Shall I start?
Yeah.
Okay. Thank you, sir. A very good evening to one and all. For those of you who are who do not know me, I am Dr. Karthik, and I'm a practicing neonatologist at Coimbatore. I work at Women's Center by Motherhood. Manage a level 3 NICU in our center. And at the outset, I would like to thank the organizing team of the IAP Tamil Nadu State Chapter for this invitation. And I'm happy to be here. And I'm going to talk on the rational use of antibiotics, particularly in neonates. And as Sir earlier said, there's no doubt that one of the most commonly misused or abused drug throughout the world is the antibiotics. And probably that's the reason that we are encountering so much of multi-drug resistant organisms. And then nature is again teaching us that, a virus still are more powerful in controlling the world. Okay. Okay. So what is the, I'll just give a brief overview of what I'm going to talk over the next half an hour. A brief introduction on neonatal sepsis. What are the effects of antibiotics in a neonate? And what are the commonly faced challenges while prescribing antibiotics in a neonatal intensive care unit? What are the adverse effects of prolonged antibiotic therapy in neonates and why we need to be very cautious in using antibiotics? And a brief definition of the various neonatal sepsis before discussing about when to use, what kind of antibiotic to use, and how to use, and the importance of the antibiotic stewardship program in any institute. So what is rational use of any drug? So as per the WHO definition, it says, yeah, can
you switch on your video, please?
Oh, you want me to switch on the video? Yeah. Okay, can you?
Yes, you can proceed.
Okay, so what is, okay, as per the WHO definition, the rational use of any drug refers to correct, proper and appropriate use of a drug. It's basically defined by the 8 R's, which means that the drug should be used for the right indication, and the right drug should be used for the prescribed for the defined diagnosis. The dose of the drug should be appropriate for that particular individual and for that particular condition. The drug should be administered at the right time through the appropriate route, and a trained personnel, trained staff should be there to provide the medication. And the particular drug should be used for the right duration, not too long or not too short. And the drug should be provided at a reasonable cost. Only if you satisfy all these 8 R's, then one can say that we are actually using a particular drug rationally. Otherwise, it's still we are using it irrationally. So coming to neonatal sepsis, we all know that the sepsis, the infection in neonates is the most important cause of neonatal morbidity and neonatal mortality. In fact, it contributes to a very significant portion of the infant mortality rate. And preterm babies, and particularly small for gestational age babies, are at very high risk of infection. The smaller the baby, the more preterm the baby is, the more is the chance of infection. Let's say again, because of varied reasons, because these babies lack IgM, because the production of IgM starts sometime after 38 to 40 weeks of gestation. The transfer of IgG antibodies actually takes place after 30 weeks of gestation. So these babies often lack sufficient amount of IgG. The immune response is very poor, both antibody-mediated immune response as well as the cell-mediated immune response is very poor in neonates. And these babies, when they're born prematurely, these babies are admitted in the NICU and they undergo various invasive procedures, which invasive procedures which again predisposes babies for various infections.
Okay, sir. Thank you.
Whereas a fetus inside the womb is in a sterile environment. So once the baby is born, the baby is exposed to various organisms from the maternal vaginal tract, the organism from the rectum, the organism from the perineum, infect the babies or colonize the babies, and some of these cause problems in babies. And again, a preterm baby, once admitted in the NICU, the nursing environment again exposes these babies to various organisms. The manifestation of infection in neonates are very non-specific, and it's sometimes very difficult to make a diagnosis of infection, and these babies deteriorate very rapidly. So there's no doubt again that antibiotics, antibacterial drugs, antiviral drugs are in fact lifesaver for these small babies. So it's a double-edged sword. It's both a lifesaver. At the same time, if not used appropriately, it can cause various complications in neonates. Coming to the effects of antibiotics in neonates. Now, the gut of a fetus is sterile. There is hardly any organism in the intestines. The flora of the neonatal intestine is established in the first few days of life. I'll come to that, what kind of flora is there in the immediate postnatal period, how it's established. The use of antibiotics actually delays the microbial colonization. Of course, all babies, all preterm babies, when they are admitted in the NICU, they are symptomatic babies require, they are immediately started on antibiotics, and use of antibiotics actually delays the colonization of the intestines. There are some studies which have shown that the concentration of lactobacillus and bifidobacterium is only 1/15 of what it should be at day 30 of life. Prolonged use of antibiotics also limits the number of the bacterial species, both commensals as well as the other bacterial organisms. There is an inverse relationship between the duration of antibiotic and the number of species. The longer the duration of antibiotic, less will be the number of bacterial species within the intestines. And use of prolonged antibiotic therapy also promotes overgrowth of other bacterial species. Some of them are pathogenic. So the bacterial diversity within the fetal gut is restricted, and the volume of these commensals are also restricted. And of course, we are all aware that these commensals, these bacteria play a very important role in immunomodulation, immunoregulation of the gut, and prolonged use of antibiotics actually predisposes to necrotizing enterocolitis in these babies. This is a very, very beautiful depiction of the gut microbiota in term babies and preterm babies. And for understanding the red line, so the first box is for the staphylococcus, the second is for the enterococcus, the third is for the enterobacteriaceae, and fourth is about the bifidobacterium. The red line actually indicates the gut microbiota in a term baby. The green line and the blue line actually represents gut microbiota in the preterm babies, extreme preterms and very preterms. The x-axis represents the gestational age. The y-axis represents the percentage of these organisms as measured by relative abundance. If you carefully look at this particular graph, this published in 2018 by Probable et al., you find that a baby who is born at term, if you carefully look at the red line, somewhere around 38 to 40 weeks of life, there is hardly any staphylococcus, enterococcus, enterobacteriaceae. Whereas in the immediate postnatal period, you find that the bifidobacterium, the red line actually shows an increase in concentration, which means that immediately after birth, the concentration of commensals increases. Once the baby starts feeding on mother's milk, there is hardly any pathogenic bacteria, rather it is the commensal which actually colonizes the gut. Whereas if you look at the blue line and the green line, say for example, a baby is born at say 30 weeks or 28 weeks of gestation, if you carefully look at the x-axis, you find that the blue line and green, you find a huge amount of pathogenic organisms, particularly the staphylococcus, enterococcus, enterobacteriaceae, and in fact, it takes about few weeks for the concentration of bifidobacterium to reach about, say, 50% of the total organism. So the microbiota in preterm babies, whether the babies are put on antibiotics or not, is completely different from what is there in term babies. In fact, this picture is completely complicated by the use of antibiotics in preterm babies, because most of these preterm babies end up in the NICU and end up getting antibiotics. So what does the early gut microbiota look like in term babies? For example, in term babies are born by normal vaginal delivery. The gut microbiota is colonized. The gut is colonized by lactobacillus, bifidobacterium, pivotella, etc., which are immunomodulators, which are probiotics. In term babies who are born by LSCS, the gut is colonized by the various skin organisms like the Staphylococcus, Propionibacterium, etc. If you look at the preterm babies, whether they are born by normal delivery or by LSCS, the gut is colonized by the pathogenic organisms, the Staphylococcus, E. coli, Klebsiella, which are there in the NICU environment. So the gut microbiota is completely different in preterm babies as compared to term babies. So again, if the antibiotics are not used rationally, if there is irrational use of antibiotics, of course, the gut microbiota gets altered. There is increased antimicrobial resistance, and we may end up in adverse drug reactions, a lot of medication errors. And unnecessary use of antibiotics also leads to unnecessary cost, which again may break the patient confidence in the treating physician. Now, what are the factors that actually lead to irrational use in antibiotics? So some of these factors, which we carefully look at, it's predominantly the lack of knowledge, because everyone is aware that, since antibiotic is one of the misused drug, if one is not aware of the baby's clinical condition, one is not aware of the, the usage of the drug, then you end up giving the antibiotics irrationally. And the other important thing is not many units have a policy. So again, whenever if one is managing a neonatal unit, looking after small babies, it's always better to each unit has their own policy, because hello
screen. Yeah, can you share your screen, that slides?
Right, it's visible. It's visible. It's visible.
It's visible, sir.
You are having a problem. You are having a problem with your network.
Okay. Sorry, continue. Okay.
Yeah. So each unit should have their own policy. What antibiotic they are going to use, depending on the kind of organism that they separate in their unit. And again, the other factor that contributes to unnecessary use of antibiotic is to have a wrong diagnosis. If your diagnosis is wrong, then you might end up in using antibiotics unnecessarily. The other important factor is the fear. So if we do not want to lose our baby, so the fear of losing patient is again the very important reason why antibiotics are used unnecessarily. The other few reasons which I would quote is the free availability of few drugs. Sometimes the parents may not be able to afford a certain drug, so you might have to compromise in choosing another particular drug for that particular patient. And of course, unethical practice all contributes to irrational use of antibiotics. So if we can address these issues, having a unit policy, having a proper diagnosis, looking at the evidence, again, one can avoid unnecessary use of antibiotics in babies. Now, with respect to NICU, what are the challenges that we face in choosing the antibiotic? The unique challenges in NICU, first and foremost, is the clinical signs in babies are very non-specific. Even a non-infectious process, for example, a baby who has apnea, just apnea alone may look like the baby is having an infection. A baby who has gastroesophageal reflux may show signs of tachycardia, tachypnea, which again resembles infection. So that a lot of non-infectious pathologies in neonates can mimic infection in babies. So we have to be very careful while making a diagnosis. And again, in very small babies, a baby who is weighing just about 700 grams, it's very difficult to obtain sufficient blood quantity for culture. If you look at any microbiology book, or if you talk with any microbiologist, they would require a minimum of 1 ml of blood to isolate the organism, or at least 2.5 ml samples to get the to have a good culture for obtaining positive blood culture. Sometimes in these babies it becomes difficult, so you might have to end up treating with empirically in these babies. Sometimes even if you're able to isolate an organism, like coagulase negative staph, still you are in a dilemma whether it is a contaminant or whether it is the actual organism which is causing trouble in this baby. So some of studies have shown that the use of antibiotics in just a clinical sepsis is several times higher than in a proven sepsis. In fact, the blood culture, we all know that it's positive only in about 20 to 30% of babies. So these are some of the unique challenges that we face in NICU while prescribing antibiotic policy. The other important challenge in NICU is about the trends in early onset sepsis and late onset sepsis. The classical definition of early onset sepsis is if the onset of symptoms is before 72 hours of life, it is considered to be early onset. The infection is transmitted from the mother, from the maternal vaginal tract, and the baby is predominantly used to present with respiratory symptoms. Whereas the classical definition of a late onset neonatal sepsis includes onset of symptoms after 72 hours of life, and most of these infections are horizontally transmitted from the hospital environment. Mostly are nosocomial, and these babies present with systemic signs. But these definitions do not hold true now, because it may hold true in a developed country, in a NICU in UK, US, yes, these patterns may be completely different. Whereas in our setup, in Indian scenario, the organism profile is similar, whether it is early onset or late onset. The organism profile is very similar. So the trends are completely changing. So there's no clear demarcation between early onset and late onset. If the area where the baby is cared for, the labor ward is not properly maintained, the NICU is not properly maintained. The moment the baby gets to the NICU, the moment the baby gets an invasive line, the baby is like to get an acquired infection, nosocomial infection. So the organism profile is completely similar, and there is complete overlap between early onset and late onset now. The other important challenge is sometimes we might end up, continuing antibiotic for longer period of time. The reason being the illness severity. Your culture may be negative, your blood parameters may normalize, but still the baby is sick. So one may still, reluctant to stop antibiotics. So that's another important reason why antibiotics are continued for longer period of time. As earlier I said, sometimes the culture becomes unreliable. If you draw coagulase negative stuff, it is very difficult to differentiate whether it is an infection or a contamination. Sometimes some babies, the acute phase reactants still remain elevated. The use of antibiotics may sometimes get rid of the organism from the body, but because of the systemic inflammatory response syndrome, the acute phase reactants tend to remain high, which again, prompts you to continue antibiotics. False negative blood cultures. Blood cultures are positive only in about 20 to 30% of cases. If the culture is not properly collected, the blood sample is not properly collected, then the chances of getting a positive blood culture is very less. And as earlier I said, a lack of a unit policy, a treatment guideline, again, prompts you to continue antibiotic for a longer period of time. Some of the risk factors for longer antibiotic therapy include this Coppola et al. In Journal of Pediatrics published that the baby who is born with an extreme low birth weight, with a smaller gestational age, baby who is asphyxiated at birth with an Apgar score of 6 at 5 minutes, baby requiring endotracheal intubation, surfactant administration, more number of ventilated days, or requiring oxygen for a longer period of time, with a history of maternal chorioamnionitis, tend to receive antibiotics for a longer period of time as compared to other babies who do not satisfy these criteria. Now, what happens if these antibiotics are continued? I mean, the antibiotics are given empirically for a longer period of time. Cotton et al. Published in Pediatrics, where they looked at extreme low birth weight babies. About the total number of babies was 5,693. This particular study showed that if the empiric antibiotic is continued for each additional day, there is a 4% increased risk of necrotizing enterocolitis, and there is a increased chance of death. That is, prolonged antibiotic therapy defined by antibiotic more than 5 days. Empirical antibiotic therapy more than 5 days in the absence of a proven infection. For each additional day, there is an increased chance of necrotizing enterocolitis and death. Similarly, Coppola et al. Published in Journal of Pediatrics, where they looked at 300 neonates less than 32 weeks and less than 1,500 gram birth weight, who survived for more than 7 days. Again, prolonged use of empirical antibiotic therapy was associated with higher incidence of necrotizing enterocolitis, late onset sepsis, and death. Again, prolonged antibiotic also increases the risk of invasive candidiasis. Use of broad spectrum antibiotics, particularly third generation cephalosporins, is associated with an increased risk of invasive candidiasis, and the incidence of invasive candidiasis varied from 2.4 to 20% in this particular study. Unnecessary use of antibiotics for a longer period of time increases the hospital stay. increases the risk of antimicrobial resistance, particularly multiple drug resistance with increased mortality rate. Now, this is a very important study which I would like to quote here. I think this will probably reflect what is happening in India as well. So this is a study published in British Medical Journal 2009. It's about the neonatal sepsis in South Asia, the spiraling antimicrobial resistance. It's basically based on the literature review where several studies were collected from PubMed and Web of Science. And this particular study included 109 studies. About 69 studies were included from India, 16 from Pakistan, 7 from Bangladesh, 14 from Nepal, and 1 from Sri Lanka, and 2 multinational studies, the young infant study and the etiology of neonatal infection in South Asia study. Now, what did they find? So if you look at this particular, this is very important, which I would like everyone to concentrate. Now look at India. The total number of studies included were 64, which included about 18,761 isolates. So if you look at the incidence of culture positive sepsis for every 1,000 live births, it's about 16 in India. For every 1,000 live births, we are having about 16 culture positive sepsis. And the case fatality rate, that is for every 100 culture positive sepsis, the case fatality rate is 34.4%. And this includes, all neonatal age group. So it's very alarming that for culture positive sepsis, like 1 in 3 babies will die. And about 34 from India, 30 from Pakistan, and total is about 34. And if you look at the organisms that are isolated, about 50% of these isolates are Klebsiella. The 42% of these isolates were E. coli, and 43% of the isolates were methicillin-resistant Staphylococcus aureus. Even though we say that viral infections are still playing a role, this particular recent study where they specifically look, these studies were included over a period of 10 years, that is from 2009 till 2018. And over the last 10 years, the bacterial pattern has not changed much. In the sense, it's the same Klebsiella, E. coli, MRSA, which are contributing for the culture positive neonatal sepsis with a very high case fatality rate. And the reason for very high case fatality rate is probably because of antimicrobial resistance. This is a study which includes both hospital and community-based studies. So it's, and again, when they looked at the sensitivity pattern of these microbial organisms, now if you look at the first half of the tabulation, if you look at the hospital setting, if you look at Klebsiella, E. coli, Acinetobacter, Staph aureus, you find that almost they are more than 80% of them are resistant to ampicillin, about 70% are resistant to gentamicin, and almost close to 80% are resistant to cefotaxime, ceftazidime. Luckily, still meropenem, they are not, many of these organisms are still, sensitive to meropenem. And if you look at the community setting, the Klebsiella, E. coli, and Staph aureus, they are still, majority of them are resistant to ampicillin, and however, they are sensitive to gentamicin, sensitive to cefotaxime, ceftazidime, and meropenem. So it's still very clear that the pattern has not changed. We get more drug-resistant organisms in the hospital setting as compared to the community setting. And this particular study, this particular research has clearly shown that the group B Streptococcus, which is considered to be one of the major organisms causing neonatal sepsis in the Western world, in UK and USA, have still not been isolated in the South Asian region. Of course, there are a few incidences where we still isolate group B Streptococcus in neonates, but still these studies are still just strengthening what was there earlier. The same pattern of organisms, even though there is a overlap between early onset and late onset, but the pattern of organisms are the same. And the significant finding is the majority of them are resistant to the commonly used drugs, ampicillin and gentamicin, which is very alarming. Luckily, till now, still majority of them are sensitive to meropenem. So before going into what when to use antibiotic, what kind of antibiotic to use, and how long to use, let's look at few definitions to just for clarification. Neonatal sepsis can be broadly classified into 3 different types. Like, we label it as suspect sepsis, where you suspect an infection, a probable sepsis, and a proven sepsis. Now, when you say suspect sepsis, it means that the baby is at risk of infection, which includes, the baby has some symptoms, minimal symptoms, but your laboratory findings are not conclusive. So basically, you just want to rule out infection. And sometimes, in a perioperative situation, the babies are exposed at risk of infection because of the exposure, because of the surgery. So these situations, we label them as suspect sepsis. The other important category is the probable sepsis, where the baby has all the clinical evidence of sepsis, like the baby has clinical findings suggestive of infection, but laboratory findings are, which shows the counts are abnormal, the CRP is elevated, the X-ray is abnormal, but the culture is negative. You are not able to isolate an organism from the blood. So probable sepsis includes, pneumonia, feed intolerance, NAC, and in even situations where you are not able to make a diagnosis, sometimes you end up treating like probable sepsis. The third important category is proven sepsis, where there is definite sepsis. The clinical findings are suggestive of an infection, and your blood culture is positive. So you might be able to grow up organism from the bloodstream. It could be bloodstream infection, or it could be a catheter-related infection, or from other sites. Sometimes you might be able to isolate the organism from the CSF, abscess, urine, etc. Or it could be a local infection like cellulitis, thrombophlebitis. So this is a proven sepsis. Now, why this categorization is important? Because this again helps us in rationalizing or in formulating the antibiotic policy for any given baby. Now, these are some of other definitions, like, what do you call empirical therapy? Empirical therapy, where you start the baby on antibiotics, but still you're not made a diagnosis. So that is called empirical therapy. Definitive therapy is where you make a diagnosis of infection and then you treat it. So that is definitive therapy. Prophylactic therapy, as I said, in a perioperative situation, sometimes at risk of infection, the babies are put on prophylactic antibiotics. As such, in neonates, there is no role for prophylactic antibiotics as of now. So empirical therapy, so in a case of suspect sepsis, where you suspect infection, the culture is pending, you start the baby on empirical therapy. So when you stop your therapy by about 3 or 4 days, you label it as limited therapy. When you continue it for more than 5 days, then you label it as prolonged therapy. As I quoted earlier, the prolonged empirical therapy is harmful. So even when you start on empirical therapy, it's always better to have a policy so that, you stop antibiotics earlier once the baby improves. Now, coming to the last part of my talk, how to rationalize when to start antibiotic in a neonate. Now, a baby is born. Now, where does the confusion start? Now, you have a baby who is asymptomatic, but you have a lot of risk factors. Say, for example, mother may have features of infection. There can be prolonged ruptured membrane, maternal fever. But you find that, the preterm baby is absolutely fine, breathing well, temperature is normal, no tachycardia, no tachypnea. The question that comes to your mind is, does this baby have an infection? What is the chance that baby becomes symptomatic because of this infection? Now, how to pick up such infected neonate, how to differentiate these neonates from those babies who are not infected. The other scenarios where you have symptomatic baby is having some features of infection. The dilemma is whether are these symptoms because of infection. Now, how to prove that these signs are because of an infection, not because of any other illness. So that's how the confusion starts. Now let's look at few scenarios. Now we have scenario 1. There are risk factors in the mother. The baby is asymptomatic. The risk factors include, prematurity, prolonged ruptured membrane, sometimes maternal fever, maternal tachycardia, etc. But the baby is well. Now 3 options are with us. Now, either since the baby is well, some would like to wait, watch, and then act. Some would, start antibiotics based on risk factors. Or some would investigate proactively for evidence of infection. Now, option 1, now wait and watch approach. Now, this again is little tricky because it again depends on, like, if you leave such babies without antibiotics, how many of them would eventually become symptomatic? Now, this is a very good study which published in way back in 2003, where they found that in babies who are more than 35 weeks of gestation, if the baby is asymptomatic, even with risk factors, only 1% of them actually turned out to be symptomatic. So in a situation where the baby is your clinical finding, if your clinical acumen is good, if the baby is clinically well, even in the absence of risk factors, you can still wait and watch, because not many babies would turn out to be symptomatic. But again, in this situation, you need to have a close monitoring. You should train your staff to look for subtle signs of infection. Otherwise, you may end up a baby becoming sicker. The other option for a asymptomatic baby with risk factors is based on the risk factor based approach. This is more commonly used. A lot of risk scores have been devised for these asymptomatic neonates. One of the risk scores that I would like to say here is by the Reddy et al. It's again, various factors were looked into based on the multivariable regression analysis. These are the factors which are used for assessing the risk score. One is intrapartum pervaginal examination more than equal to 3, presence of clinical chorea neonates in the mother, birth weight less than 1.5 kg, male gender, mother not receiving intrapartum antibiotics, gestation less than equal to 30 weeks. So each factor is given weightage. And if the total score is 6 and above, then there is a very high probability of the baby becoming symptomatic. So asymptomatic baby, risk factors, one option is to wait and watch. The other option is, the risk factor based approach, where based on these risk factors, if the score is more than 6, one would like to start the baby on antibiotics, because the chances of such babies becoming symptomatic is very high. The third option is to straight away investigate immediately and then start the baby on antibiotics. But since in asymptomatic babies, there is no ideal screening test to identify these neonates at risk of developing significant infection. So there are various screening tools, but none of them is a single screening tool is not the ideal one to pick up the early onset infection. So a combination of tests could be useful. I'll show you what they are. Now coming to scenario 2. So scenario 1 is an asymptomatic baby with risk factors.
Dr. Karthik, sorry to bother you.
Yeah.
Another 5 minutes.
Yeah. I'll finish. I'll quickly wind up. The other scenario is a baby who is symptomatic due to early onset sepsis. The baby becoming symptomatic within the first 72 hours of life. So the baby is symptomatic, and the baby is, and there are risk factors present for infection. You are you can go ahead and treat with start the baby on antibiotics. And scenario 3 is symptomatic, where you suspect a late onset sepsis and nosocomial infection. Baby developing symptoms after 72 hours. With the clinical signs, one can make a diagnosis of an infection, and some of the blood tests can be used, which will help in predicting infection. So simple approaches. Asymptomatic risk factor based approach is useful. For a symptomatic neonate, if there is low probability of infection based on your clinical examination, you can do a screen. If the screen is negative, you can wait and watch. If the septic screen is positive, you can start the baby on antibiotics. If your baby is symptomatic and your clinical examination suggests you have high probability of infection based on various other factors, then you can go ahead and start the baby on antibiotics. Now, what antibiotic to start? Now, the choice of empirical antibiotic therapy, if you look at the guidelines from the developed nations, they say start with ampicillin and gentamicin, because the group B streptococcus is very common here. Whereas in our country, it is again very important that we have to individualize. We have to individualize on what kind of bacteria that we separate, we isolate in our unit. So based on our own culture sensitivity pattern, it's always better to start our unit policy, to frame a policy. So what we do are in NICU. So our first line antibiotics is basically ampicillin and amikacin for in utero intramural babies. For outbound, where sometimes we suspect staph infection, we start them on ampiclox, because clox is not available separately. So we use ampiclox and amikacin. Our second line choice is piperacillin, tazobactam, and amikacin, or piperacillin, tazobactam, and vancomycin. And our third choice is meropenem and vancomycin. If your infection control measures are stringent, if you are maintaining a very good asepsis protocol in your unit, then you won't be reaching the third line at all. I would say in the last 2 years, hardly we have used meropenem in 3 or 4 babies, not more than that. So most of our babies end up with ampicillin and amikacin alone. So how long to give? So for the duration of antibiotic, one has to a full diagnostic evaluation is important, looking at the blood count, CRP, other infective markers like procalcitonin, blood culture, etc. The most important is you have to trust the lab. If your sampling should be adequate, and you have to trust your reports. If the serial CRP is normal, or if your serial procalcitonin levels are normal and your culture is negative, baby is clinically well, you can stop antibiotics after 36 to 48 hours. You can use the help of various biomarkers. Just like to quote this NeoPen study, which looked at the procalcitonin guided therapy. Procalcitonin is a very important inflammatory marker which rises even before CRP. It helps in making a diagnosis, at the same time helps in guiding your antibiotic therapy. About 100,710 groups were divided into 2 groups. One, the decision of antibiotic was based on procalcitonin. In the other group, it's based on the standard therapy. For the procalcitonin group, the duration of antibiotic therapy was less. So, but of course, getting this test done is a little difficult because it's a little costlier as compared to the CRP. So this is the nomogram to say that if the procalcitonin level is high, more than 0.5 microgram per liter, the chance that baby has an infection is very high. If the procalcitonin level is less than 0.5 microgram per liter, the chance of the baby having infection is less. So these are the various biomarkers which can be used. Commonly used one is the CRP. Procalcitonin is now seems to be a promising tool. So we need to look at the lab cost and the affordability, the feasibility before getting the levels done. So how long to give? If the baby, in a case of suspect sepsis, culture negative, the baby is well, once the blood culture is negative, you can stop antibiotics by about 36 to 48 hours. So once you start the baby on antibiotics and suspicion of infection, it's always better to have an early exit policy. And if the baby is still symptomatic even after 48 hours and or showing clinical deterioration, then only have to think about upgrading antibiotics as per your unit policy. And as I said earlier, look for other etiologies. Bacteria is not the only cause of infection, is not the only cause of clinical deterioration in neonates. There are cardiac causes, other non-infectious causes which may have to be looked at. You have to reevaluate antibiotic regimen every now and then. Look for non-infectious etiology. This particular study, the etiology of neonatal infection in South Asia study showed almost equal viral infections in babies from 0 to 60 days of life. This includes both hospital and the community-based study. And one of the common viral infections that they have isolated is the respiratory syncytial virus. So the baby is not responding to antibiotics. Think of other non-infectious causes. How long to give? If the culture is positive, no evidence of meningitis, 10 to 14 days is sufficient. Once the culture is positive, it's always better to narrow down the antibiotic based on the sensitivity pattern. Choose the antibiotic that is least toxic. At the same time, look at the cost as well. In case of culture positive sepsis in the presence of meningitis, one may have to continue antibiotics for 3 weeks. And you might have to choose an antibiotic with good CS of penetration in the presence of meningitis. Again, even if the culture is positive, you have to reevaluate your antibiotic regimen. First, look at the site of collection. Sometimes growth from a non-sterile site, for example, a tracheal aspirate may indicate colonization, not necessarily infection. So you have to take that also into account before changing your antibiotic. And once the sensitive pattern is available, narrow down your antibiotic and stop the empirical antibiotics for which the organism is resistant to it. Suppose if you are isolating a gram-negative bacillus, then there's no point in continuing with vancomycin, because that sometimes you may end up when generating resistant organisms. The third important factor is timing of microbiology report. So you have to discontinue antibiotic therapy as early as possible, because most of the meaningful blood cultures should be positive by 48 hours. If you're not able to isolate an organism by 48 hours, then it's very unlikely that in the sense if you are isolating an organism after 40 hours, there is a very high chance of a contaminant or colonizing organisms. So delayed growth may indicate contaminants or colonizing organisms. So when do you upgrade empirical antibiotics? If there is no clinical improvement with the current antibiotic, you may have to upgrade. For any antibiotic, give at least 48 to 72 hours time before you say that this antibiotic has failed. I've seen people changing antibiotic every day. So don't do that, because your inflammatory markers will rise for a couple of days before they start coming down. So clinically look at the baby. Once you start the baby on antibiotic, wait for at least 40 to 72 hours before changing. Okay, antifungal, there's no role of prophylactic antifungals in neonates. There are some risk factors for fungals. Only in those babies who require prolonged antibiotic therapy or in NICU for a longer period of time, beyond 4 to 6 weeks of life, may require antifungals. Okay, so just to conclude, the 10 fundamental questions that one has to answer before starting antibiotic. The first question is the patient infected with a bacterial agent, or is it a non-infective etiology? Do I need to start the baby on empirical antibiotic based on your clinical findings, whether it is suspect, probable, or proven infection? And you have to be careful while choosing the antibiotic. Make sure that it is less toxic, and put every effort to have a microbiological diagnosis. Make sure that you collect relevant samples, and always look at maternal blood reports, urine culture reports as well before you make a decision to start antibiotics. Look at your unit organism pattern. Are you dealing with drug resistant, multi-drug resistant organisms like MRSA, ESBL, etc.? And what is the most appropriate antimicrobial therapy? And what are the factors that you need to look at while giving antibiotic therapy? And have a clear-cut idea about the duration of antibiotic, whether you're going to give it for 3 days, 5 days, or 7 days. So, and above all, the most important thing is infection control measures. If your unit is infection-free, if your asepsis protocol is stringent, then you are unlikely to get more infection. So your usage of antibiotic will be very minimum. Thank you. So I think I'll stop here. Thank you, Dr. Thirumurugan. Thank you all. Am I audible?
Yeah, thank you very much.
Yeah,
thank you.
Yeah,
Great, Balan, sir.
Thank you, Dr. Karthik Balasubramanian, for your vivid presentation
Thank you,
on
sir.
the rationalizing antibiotic